Welcome to Quad A Now, where we explore the world of patient safety, the impact of accreditation, and other topics relevant to outpatient healthcare facilities and dental practices. Join us as we explore diverse topics, share success stories, and navigate the challenges that define the pursuit of excellence in patient safety.
Welcome to the Quad A Now podcast. I'm your host, Tom Terranova, CEO of Quad A. Today, we're honored to welcome Dr. Samuel Lin, a true leader in the field of surgery and innovation. Dr. Lin wears many hats. He's the Director of Aesthetic Surgery at Beth Israel Deaconess Medical Center, Chief of Plastic Surgery at Beth Israel Deaconess Hospital Needham, Associate Professor of Surgery at Harvard Medical School, and the Executive Director of Harvard's Surgical Program in Innovation. He also serves as the Residency and Fellowship Director and is an attending plastic surgeon with Harvard Medical Faculty Physicians at Beth Israel Deaconess Medical Center and the Massachusetts Eye and Ear Infirmary, so he's quite busy. Dr. Lin is also double board certified in plastic surgery and otolaryngology and head and neck surgery, and his groundbreaking research at Harvard has focused on improving surgical safety and outcomes. Importantly, his work leverages Quad A's unique proprietary patient safety data reporting, known as PSDR, to help identify best practices that reduce risks and complications in the operating room. Dr. Lin and his team have published 4 impactful papers using PSDR data, which we'll discuss later in this episode. Let's dive in and hear from Dr. Lin about the cutting-edge work that's shaping the future of surgical safety and innovation. Welcome, Dr. Lin. It's a privilege to have you with us today.
Thanks so much, Tom. And thank you so much for the invitation to speak with you and in Quad A. And I really have appreciated our long-term working relationship, trying to bring the best information, the best data to facilities and to patients.
Well, thank you for all the work that you guys do. So I think you just brought up a great starting point for us. So to start with, maybe you could just tell us what sparked your interest in and awareness of the PSDR data and what really brought you to looking into this data as the basis of a lot of your research.
Well, let me back up a little bit. I can kind of speak to our team at our medical center. We have it's a credit to the team. I'm just sort of putting things together and organizing things, but it's really the team that has done the work and on the ground to really make all this data come to life. So we've been working on large database studies, national databases, different sorts of things, insurance types of databases for a number of years, to try to find commonalities and themes for patient safety. Traditionally, in medical literature and publishing and studies, we've had traditionally single institutional studies that have been limited by the number of patients because it comes from a single hospital, a single medical center, and then multi-center sort of trials or studies are certainly better in terms of the number of patients and quality of data, but sometimes that is still the number of patients is limited. And certainly the data use agreements between institutions and IRBs and regulatory standpoint makes it a challenge to really be nimble and try to leverage the data. On the flip side, with large database that are available publicly and otherwise, you have a number of patients that can be used in terms of the numbers of patients to understand trends, but then the granularity of the data has sort of been a limiting factor. Years ago, when we met other members of your board and visited facility and headquarters in Chicago, it really came to be that it was really great interesting opportunity to leverage what seemed to be a black box still to this day and age in terms of medical and patient data, and that is the outpatient space. So a lot of these national databases that we still use and we still analyze data from are from hospitals, systems across the country, across the world, but they lack that granularity in patient information.
And that's, I just want to interrupt you for 1 second to clarify if I'm wrong, because I hope I'm not being too ambitious in saying that I think that the more we have really great insight from people like you on this podcast, the more we're likely to be speaking not just to physicians and colleagues of yours, but also to the public and patients who may not realize that what you're just saying there. I think, hospital data has been traditionally what researchers have had to rely on because they're large institutions with large patient populations and on a wide variety of specialties. But there's really been nothing in the outpatient setting. And at the same time, the mix and the volume of cases being done in an outpatient setting has shifted dramatically. Way more is done in the outpatient setting now than has ever been done in the past, and probably more than is being done in the hospital at this point. So the lack of that information and the lack of that data for a researcher would be a nightmare.
No, that's right, Tom. Absolutely. The great points have layered in a lot of additional pieces of information for that. So indeed, yes, these large databases primarily have been all inpatient procedures, inpatient complications, adverse outcomes when they happen, and really just a big black box for the outpatient set. So enter the accreditation bodies, and with Quad A being a major player in this space, and the only accreditation body that has routinely required facilities to collect data and report outcomes over, many decades has really been a positive force for patients and facilities to really understand these trends. So to go back to your original question, it was just like a really great melding of our own interest and your facility's data and structure for data reporting to really go back and try to answer some big questions. And so that was now years ago, and we've been fortunate to really be able to come through and look through several databases and versions of course, the database and how the data was collected to now where it's been really designed ground up in terms of being able to collect and ask those key questions of our facilities, which is, of course, some more effort and on their parts, but as a carry the brand and certification of a Quad A certified facility, which means a lot to them and to patients. I think it's worthwhile and well worth its time.
Well, I think that's a perfect segue because, obviously from a facility standpoint, if there's a little extra burden, a few more hoops to jump through to provide data. Also, many of us are a little bit hesitant to give certain types of data because we all want to be protective of our data. But from a researcher's perspective, this data, what does a data set like this mean to a researcher? And just to put numbers to it, you mentioned sort of when you have a single center working on research, it's really focused, and 2 centers is way more important than 1, potentially 3 centers. But from the Quad A perspective, from the accreditations perspective, not even to speak of Quad A, but there's roughly, I think, 2,500-ish facilities reporting on a quarterly basis since the year 2001. So over 2 decades, 2,000 or more facilities, multiple doctors in each facility. So to have that breadth, from a researcher perspective, when you're sort of looking at the matrix and all the numbers cascading down your screen, what does a data set like this look like and mean to a researcher as compared to sort of a more kind of focused data set for my own patients and my own population?
Yeah. No, thanks for the question, Tom. From what would be considered a large database standpoint, again, it's really importantly that granularity of what patients, for instance, surgical facilities, what procedure they had, how they did. Certainly, if there was a readmission, another procedure to take care of an issue, being able to have that captured data is really, really important. And then on that line, having a little more, again, granularity of patients, ultimately, we're like a lot of these patients, of course, are still de-identified, so it does qualify as, and it's thought of really as more of a large database, which it is, since there's over 2,500 facilities, of course, with all the procedures that are being done at each place, versus having a retrospective study into a single practice or a single few practices, which is different. But still, I think having that granularity, which is, again, maybe different than what's out there from the publicly large database, national databases, but certainly too, which is a very, very key important aspect, which is the outpatient space, which is really not captured anywhere. And so it's really important to have that information.
Thanks for that. I think it's really important, but I also think there's probably very few people listening who are researchers such as yourself. So if I could ask you to put yourself in, I guess, put on your other hat as a practicing plastic surgeon, maybe in your own practice. So if you were a colleague out there listening who runs a solo practice and is thinking about this as a pain in the neck, we'll say, to pick a polite region of the body, that it's a pain in the neck to do this. What's the perspective of what this means to me if I'm solo practitioner, not at Harvard and not doing research? Why do I care that this data set exists?
Yeah, I mean, thanks for that. We're trying to answer big questions for sure and small questions. And I would say that research is not just research for fun. The whole point is to answer an important question that hopefully answers and helps people preventatively. And so what's in it for me certainly, can be answered with some of the papers and publications and presentations that we've already put out. For instance, I think it's great to be able to sort of functionalize where you are in different parts of the country, but using the data from and leveraging the data from understanding what are things that are happening across the country in the outpatient space is going to be ultimately, I think, more future questions that we answer together. But I sort of draw attention to a paper, or sort of one paper published, another paper on the way, of something that we a few years ago looked at with you, and that was the whole incidence of adverse outcomes, morbidity, mortality, and the degree in which DVT prophylaxis was being performed. So this is a very known sort of aspect of perioperative management, which is, of course, the prevention of vein clots in the leg that travel, when they do, to the lungs and cause significant morbidity and, sometimes mortality, which is obviously terrible. And the fact is that there's been a lot of information that's been written about this over the years about stratifying risk, different scores that have come from it, clinical scores to understand who needs what in terms of prophylaxis. Is it just boots and the TEDs? Is it heparin, subcuheparin? Is it Lovenox? All these things have been studied many, many times and written about profusely. Yet, going back to the data and looking at the facilities and with your help, Tom, and team and others, being able to understand how that prophylaxis was done and if it was done and how it was assessed was really what we looked at. So we can kind of highlight that article in that of the complications and adverse outcomes, morbidities, and mortalities that we saw in the patients in the facilities, and how many of those patients actually had screening for DVT, it clearly corresponding with the fact that the number of patients we thought we were collectively as a group screening wasn't probably perhaps as high as we thought it was. And guess what? It had an effect. And patients were having complications of clot, of pulmonary embolism, completely, for the most part, unless there's a clotting problem or other issue intrinsically with patients, but for the most part, may have been prevented, and certainly at least a little more proactive in some cases, perhaps. So we've had a follow-up study of that, and in looking at those just individual efforts of places, facilities to prophylax and what's happened with those, and again, proactively, also we see the same thing. So this is a one example, but I think an important example of what the data has been really useful to show us. And so that is one example of what a practitioner might be able to take away from this in order to just take care of patients in a different way or better, and review policies, protocols, and to make sure that everything is as current as possible. And there are other, studies and questions that I think we'd like to, work on with the quad A as well.
So, if I'm hearing you, then if I'm a solo practitioner and I'm worried about this taking time from me, the return on investment of time is that, research partners are producing insights that can help me reduce my risk of a complication and how I manage that complication potentially if it does happen, which, I've known a lot of doctors over 15 years and no one wants a complication. I think most doctors live their life sort of trying to avoid them as best they can. But to know that you have some control, I think is, I guess, a better position to be in than just sort of accepting that complications happen and sort of just living in sort of perpetual apprehension that one might occur. So I guess if I'm a solo practitioner, I'm thinking, well, the good news is there's going to be some studies that come from everything I report. And if I take those learnings, I can improve and I can avoid and I can mitigate risks, if I'm hearing you.
And also, I think that this is ultimately what the facilities are sort of getting and on their investment. I mean, obviously they need to have some sort of third-party accreditation body certify their facility for the public, certainly for the state's medical board and what have you. But at the end of the day, that additional effort of collecting the data is being utilized to as best possible. And so it's a public service, 100%. And then with that, it's, I think, a sort of a cyclical process where they should feel proud that they are Quad A certified and has taken steps to really now utilize what the resources and the data that's been provided to provide that extra value benefit to having that seal of certification, which stands and means a lot behind it.
So I was going to ask you to put yourself in the shoes of a patient because we've all been there, but I think you sort of have already done that by saying, if you're walking into a facility that is participating in a program like this, then you have a higher sense of confidence and knowledge that this person's taking proactive steps to contribute to learning, to contribute and to hopefully actualize the insights that come from the data. Because data is one thing, but it's kind of useless unless it's turned into information. And information is sort of not fully utilized until somebody does something with it. And if we can close that loop, that should breed patient confidence. And I think that's one of the messages I try to always have whenever I speak with a focus towards the patient population is we as lay people tend to assume that there is oversight and that there's monitoring and that every facility is tightly regulated when you and I know that that's not really the case. But here is a method by which a lay person can identify not just quality and not just sort of minimum standards, but that your practitioner is actively contributing to something to improve care, right? I think that's really the big takeaway as you were kind of bringing together the value to an individual practitioner as well.
Yeah, that's right. And I think as we continue to build on using the data for additional important questions, that's only going to add more awareness to that. Because I think for the patient who comes to a surgery center, probably aren't paying attention to exactly what accreditation body is accrediting the particular plex, and so I think there is a distinction that can be made.
So I think that's all wonderful, and it provides a good segue from sort of the research, how you've approached it, how you achieved, how you came into working with this data. And really, you led with my favorite of your papers, which is the DVT paper forthcoming. So I always try to describe it. You mentioned the two papers. I sort of have been recently describing the upcoming paper as sort of the culmination of a 4-paper series. If I go back to the very beginning of the data set, and Dr. Jeff Keys, who had originally conceived of this, along with some other colleagues, writing on the incidence and prevalence of morbidity and mortality in outpatient settings that are accredited versus either unaccredited centers, which are a complete unknown because no one's collecting the data, or the hospital setting, which has a little bit more data, but in order to kind of say there's comparable or even better safety. And I think that first study showed that there was comparable or better safety. The second study that I believe he and colleagues conducted identified that where there still were adverse events and where there still were, unfortunately, mortality, DVT or VTE or pulmonary emboli were the leading causes. So broadly speaking, those clots were the leading cause where death still did occur. And so I think that was the impetus for our organization, at least, to put in requirements for screening processes. And then you wrote the 2 follow-on articles, which, I'd love for you to expand on, but briefly, one sort of said, when there still happens to be adverse events with VTE, did the screening occur correctly? And this final one, which I think is the most powerful, was correlating how often inspections found that facilities were complying with the screening process and tying that to a link with adverse events, if I'm not mistaken. This is my favorite article because it kind of closes the loop, but there are others, but I want to start with this one.
Yeah, thanks, Tom. I also want to bring up the fact that the Quad has been really a great partner and nimble in the fact that on learning information that they're able to act upon. So I want to bring back to that third paper a couple points. One, all along, it's been one of the biggest things when we submit papers, research papers, scientific papers to journalists, we have reviewers that ask us questions, and I think it's just a helpful process to just make papers even better. One of the questions that always comes up is, what is the denominator? How many procedures are really talking? And that's been an evolution too, as well. So I think one, finding out the true incidence and true sort of N has been that. So I think I'm fairly happy and confident working with our team, your team, that we have as close to a true N as we can possibly have, and given all the facilities. The second thing is, with that new information that came out in plastic and reconstructive surgery, was this revealing information about not every place was screening for DVTs, which seems like a very common thing that people would do, given all the literature out there, but just frankly, just wasn't happening in every place. And so the Quad came up with a new policy. They changed, I think, your policy, or came up with a new policy around that, which I think has been really beneficial in preventing morbidity, mortality, to now where this last paper, which is not yet published yet, but basically shows that post policy change, that the places that have really adhered to it, stuck to it, followed it to the letter, have done fine in terms of preventing DVTs, pulmonary embolisms. Those that did not, perhaps didn't have that same effect. And that is that will be forthcoming in an open access journal, within the next year for sure, probably a few months, more realistically, for us to learn from. And so it's been helpful, and I'm glad to have been a part to kind of share that and being able to work with the Quad on that.
Thank you. So I do, again, I want to make sure that I'm also, I guess, translating for folks who are not as familiar with research. You mentioned the N, and I think it's important. Many other, you can correct me because you're more familiar with other data sets, but at least many of the data sets I've become aware of or that I've been exposed to, there might be a count of adverse events. So if we take it away from DVT, we might have 30 infections or 35 infections, and that's sort of just a blanket statement. There's 35 infections, but it's really important to know if that 35 infections is out of 100 cases, 1,000 cases, 1,000,000 cases. And that's really what you're talking about as being the N. For anybody who's not familiar with research, is that to know really what the risk factor is to know out of how many, one out of how many patients will actually experience this, if this occurrence, if things are done right versus if things are done wrong, and what impact can we have based on our actions? Would that be a sort of an accurate translation for folks who are not researchers?
Yeah, that's right. And just like a probability number of times is still the thing's going to happen over the year of events. And when you have so many facilities and so many procedures going on, it's really trying to make sure that the denominator is as accurate as it could possibly be.
That's fantastic. Okay, so that's my favorite set of articles, just because I think the correlation, obviously, between the compliance with the requirements and the incidence of adverse events and how they sort of go in lockstep is, I think, really critically important, and it's probably some of the most powerful insights that I've seen from any of your team's research so far. But I know you've written other papers. And so I would love at least to give both physicians out there who are listening and patients a sense of some of the other papers that you've written with the PSDR data. And really, if you have anything else, other good research data that you just have great insights coming forth. I know there's some cannabis use research that you had done, and as well as some research on abdominoplasty and fat grafting. So if you want to talk about that, those other research papers that you did and any other really interesting topics that you see on the horizon, I think it's a great opportunity to sort of pique the interest of people who might be listening.
Sure. Thanks, Tom. I just can reference sort of some of the other things that we have done together. Some of them have been more relevant in terms of getting more attention on the airwaves. And let's just talk about that, which is fat grafting, for instance, to the buttock region. So the Brazilian butt lift BBL procedures, which over the last 10 years have gotten a lot of, let's just face it, a lot of attention, sometimes unwanted, related to the morbidity and mortality of patients dying from these procedures. So having it be one of the most risky procedures in what we do in plastic surgery. So guidelines, societies have gotten involved and coming together to provide guidelines around that over time. From our research standpoint, we've sort of looked at those cases and those adverse outcomes from the Quada's databases and really understood where and how those procedures are being done. It's known that still, and some of this is confirmatory, but still, I think, relevant, that in the highest incidence of morbidity, mortality of cosmetic procedures still is our contouring procedures combined with liposuction. So I don't think that's going to really shock anyone out there who's a plastic surgeon, but that really still is the case. And just that, I think, a combination of fluid shifts, liposuction, depending on the volume, higher volumes, and insert contouring procedures that tend to be lengthier cases, and the immobility of patients afterwards, sort of all contribute to the fact that these patients have a regular amount of morbidity and clot formation and uncommonly, but still more mortality that we're all trying to pay attention to. And that obviously is what inspired us to try to look at that DVT information initially in those two papers, projects, to really understand and how to prevent complications. But clearly, a lot of that is, in terms of the BBL information, is really been worked on by the societies and lots of people trying to help and educate practitioners on how to do these procedures safely. But there's, other questions that we want to address, look into with you and your team, again, all related to patient safety. There's always the aspect of implants, breast implants, and safety, and lots of discussion around that as well. And that's gone up and down in terms of in different regions of the country too, regarding choice of implants, size of implants, breast implants, of course, since for many years, and certainly since early 90s, when there was this purported link to autoimmune disorders, which has been disproven, of course. But the point is it's always been in the headlines, and I think still a lot of that is done. A lot of those procedures, of course, are done in the outpatient space. So I think we still have more to learn about breast implants. I don't think everything that we have out there is all that we've already needed to or will know about it. So that's all still, I'm just sort of postulating, but that's just one area that perhaps we can look at.
Well, anecdotally, I can tell you recent conversations I've had has been about kind of revisiting, and for those who don't know, textured implants. I believe textured implants are banned in the United States, but they're very commonplace in other parts of the world. And from my understanding, the data that led to their banning was not as rigorous as maybe we would expect nowadays. And so you sort of sometimes the things that become a ban or sort of unaccepted practice sort of become that way based on some level of understanding at the time and then are sort of ingrained, whereas there might be an ability to reapproach that question. And to your point about sort of the breadth of the data that's in this data set, is the PSDR data includes data from all over the world. And so there's even with that question, there's the opportunity to potentially in the future look into incident rates of textured versus non-textured implants to see if really the old rationale for banning them in the United States holds any water, or if it really was sort of just the best understanding at the time, but now we have new data to disprove it.
Yeah. Thanks, Tom. I just want to make a little gentle edit. So textured implants are not totally banned in this country. There's two companies that are still on the market here. It was the one company and the particular, really the method of texturing implant behind it. And certainly that has been off the market for a couple of years now with and patients coming in to exchange the inputs. But there are textured implants that are still available that are still being used.
So it's the type of texturing.
Correct.
Okay.
That's right.
Thank you for that. Yeah, that's great.
But, the implants, I would say in general, continue to evolve. There's, a new entry of a new company, recent company that is entering the U.S. market with their implants probably this year. And frankly, the implants continue to evolve in terms of size of implants, types of implants. So it's an ever evolving and ongoing process of evaluating these newer implants each year. And to the implant manufacturers' credits, there has been a lot of effort to try to make these implants better. And so certainly the implants currently of today are a lot better than they were in the past. Certainly. So it's gone.
But to bring it back to the point of sort of your research and research in general, the data is what helps overcome that entrenchment. So I think that's really the key, right? Whoever has the best data can kind of, remake that argument in the best way possible with the most recent information. So there was another thing that you said early that I think is a public service to patients who might be listening might bear some clarification. And you said any plastic surgeons out there listening will be familiar with this. And there's certainly a lot of sensitivity around people performing certain procedures, and I don't want to get into that at all. But what I do think is important for patients just to understand from a fundamental standpoint is, plastic surgery in general, especially aesthetic plastic surgery, because it is more of a market and a commodity rather than reconstructive surgery. There are different elements and different dynamics at play. And so to say a plastic surgeon versus someone performing plastic surgery services, I think is important to differentiate that those two may not always be the same, and that there's this sense of a cosmetic surgeon out there, which is really not a recognized board or qualification. So without getting into who should be doing what or who shouldn't, I just think differentiating between a there are board certified plastic surgeons, which is an American Board of Medical Specialties certifying board. And then there are people providing plastic surgery services or people providing quote unquote cosmetic services or calling themselves cosmetic surgeons who may or may not have that board certification. And not making a normative or value judgment on any of that, I think it is important to draw that distinction, because most of us lay people see cosmetic surgery, aesthetic surgery, plastic surgery, and kind of smush them into one thing. So I don't know if you have comments on that. I don't know if it's testy waters, but I think it's uncontroversial to say that there is a difference between the two things.
Yes, I really appreciate that comment, Tom, for bringing that up. And I would say that it first can be sort of equated to what we're talking about in terms of accreditation as well. So you have the bodies of accreditation that have all these line items of quality, safety that have to go into any facility. And yet you have unaccredited facilities out there that are, whatever the facility might be, someone's house or part of a house or some place that don't have the same qualifications around that. And then again, it falls down to the patient. And is the patient going to be able to distinguish what a facility is supposed to look like or not? Maybe they have an idea about that. Certainly something inherently, maybe not. Maybe they don't care. Maybe they care. Who knows? But to kind of going with what you sort of said is yes. It's we talk about this for the next long time about this. But really, I think board certification means, and that means by the American Board of Medical Specialties. So plastic surgery being the only plastic surgery, cosmetic surgery, aesthetic surgery board that's of the 22, 24 ABMS boards that is board certified carries a lot of meaning, I think. And I think taking the highest road possible to get the best training and to provide the best care patients is certainly what I've always tried to espouse to. And but there's a lot of folks that have fields that do overlap, and pay practitioners who maybe not board certified plastic surgeons try to educate themselves on a weekend course or something. And I think that's a thing that does happen. I think it's from a field standpoint. Flattery is sort of with imitation and trying to market it is one thing, but in a court of law, I think if you're being posed and asked what your specialty is and what your board certification is, maybe they'll be able to distinguish that. I don't.
Wait, yeah, and even without taking the, I try to always make a really just a kind of a normative or a normative free kind of assessment. And what I say too is typically, even if we're talking about accredited facilities, non-accredited facilities, or board certified surgeon in that specialty, or someone who doesn't carry that specialty board certification, they may not, there's nothing inherently wrong with them. That's not an indictment to say that they are inherently dangerous and wrong, but there has been a fundamental lack of a demonstration of that compliance to say, we now know that you are capable of demonstrating this level of compliance, either with the training for board certification and the board exam, or accreditation, or whatever it may be, that we at least know you've had the ability to demonstrate the level. And for the other folks, they may not, but there's a lack of awareness. Again, it's sort of that black box, and sort of what's behind the curtain is an unknown. And they could be great. They could not be great. It's just unknown. That's the way I always try to be fair about presenting it, at least in my world.
Realistically, look, complications happen to board certified plastic surgeons and non-board certified practitioners who are practicing plastic surgery. So again, it's really about the patient and what they understand, what they're comfortable with. I can only speak to what I can espouse, and that's all I can say, really.
Wonderful. Good. So I don't want to keep you too long, because as we read off your credentials, acknowledge the sheer volume of work you do and how busy you are. But I did want to make sure we cover, is there any other of the research or research topic that you wanted to really kind of highlight for folks who might be interested in looking for papers that you've already written or forthcoming? Because I know you've got a big team of researchers and you're always presenting abstracts and papers. So I want to make sure we give some breadth to all of it.
Now, I think that this is a great initiative Squad is taking forward that, you and I have been talking about for a while, which is outreach and to the public, and to really help educate and provide the value and demonstrate and why the value of accreditation and also the data speaks for itself. So there'll be more to come. I think in terms of projects, papers together, I think that'll be helpful for people, but it's been great to catch up, and thank you for the invitation.
Well, before I let you go, you mentioned education, which I think is important. Research is part of what you do, but research doesn't happen in a vacuum. So I did want to ask if you'd mind talking a little bit about the role that sort of Quad A's educational foundation. Research requires not just people to do the research and data to research itself, but it requires funding. So I wondered if you might want to talk a little bit about the educational foundation and its role in facilitating your work, and why it's so important for physicians, for industry, for a random patient out there who maybe lost a loved one or who experienced an adverse event themselves, to donate and to contribute to educational foundation, whether it's Quad A's or another educational foundation within a research society. Why funding through educational foundations are so important?
Right. Absolutely. I appreciate it. And this work, of course, gets done with the team, and their time is valuable, and really, again, for patient, family member, or our facilities and organizations that work with Quad A, or around the design, construction, and maintenance of facilities. I think clearly we're trying to demonstrate that value, which I think hopefully we've covered, and convince folks that the value of the data is there, that everything that Quad has required of facilities to provide is valuable, and that we're taking that effort and value and giving it back to facilities. And that's really, truly what that is paying it forward, using that information that they've, and that time and effort, and giving it back to what that has answered.
And so your team's research really relies on grant funding, and those grants pay for to support those researchers, to purchase equipment and software licenses to make sure that you're not storing data on Google Clouds and having sensitive data available to the first person, but also to travel to conferences and present the research and educate practitioners that ultimately can take that back.
And we're thankful for that, for sure, to you, Tom, to Bonnie, and the team, the board. 100% of those grants goes to the research and publication costs and equipment, and that's it. 100% of it goes to the research.
So I know I wouldn't put you on the spot, but I will say, for anyone interested in contributing to the educational foundation to support patient safety research, like Dr. Lynn's, there are other researchers as well, but Dr. Lynn's team has been working with our education foundation quite a bit since, I want to say, 2017. For anyone interested in contributing, please visit quadA.org/educational-foundation, and you'll find a donate now button. Click the donate now button, and you can donate as little as much as you please to make sure that there's additional funding available for researchers like Dr. Lynn's team to provide really critical information like this, to provide insights and takeaways that physicians can operationalize to ultimately protect you and your loved ones. So I'll make that plug on your behalf. And other than that, I want to thank you, Dr. Lynn, for sharing your insights and for leveraging Quad A's PSDR data to advance patient safety, because data just sitting in a server somewhere by itself is of no value. But your work is truly inspiring. Thank you to our listeners for tuning into this episode of Quad A Now podcast. If you have questions or feedback, we'd love to hear from you. Visit us at quadA.org/contact-us. To be sure to follow us on LinkedIn, Facebook, Instagram, and X at Quad A Now to stay informed with alerts, updates, and announcements about safety that are important to clinicians and patients. And for any patients out there, please feel free to visit our website at quadA.org. That's QUADA.org. where you can find a directory of accredited facilities around the world. Don't forget to subscribe to the podcast for more engaging conversation with leading experts. Join us next time as we continue exploring the critical roles of accreditation and innovation in ensuring patient safety. Until then, stay informed, stay safe, and we'll talk to you soon.
That's a wrap on another enlightening episode of Quad A Now, a global accreditation podcast. Stay tuned for more captivating discussions with leaders who are shaping the landscape of quality and patient safety. Remember, patients first, always.